introduce this event, which we are organizing jointly with the Humanitarian Health Ethics Group from Canada, and who are here for a two-day conference, which is more of a closed workshop, but then we wanted to have one evening to be able to share some of the results of very interesting research the Humanitarian Health Ethics Group has been doing, and also to have an introduction which sets a little bit the scene for small acts. This is the small things, well, small acts, small things, and humanitarian care in crisis situations. For me, I mean, when we say small acts, and you will see part of the evening will really be around small acts when you are in front of people who are suffering, who may be at end of life, where you don't have anything else to offer than to be there to help, and to help them perhaps at the end of their life in their suffering. And when I thought about the topic of the conference tonight, myself, I'm a medical doctor. I trained here in Geneva at the University Hospital here in Geneva, long time ago. And when I was an intern here at the hospital at the end of the 70s, so it's a really long time ago, this notion didn't exist. We didn't know what to do with patients who were in terrible pain at the end of their life. And I remember a cancer patient, a middle-aged woman, she was dying, everybody fled. She was in so much pain, she was crying, and nobody was helping her. And I was totally overwhelmed. I was a young intern. I had not learned how to deal with these situations. I didn't know anything. So this really remained in my head, that there's something which is terribly wrong in our healthcare system, that this is the way we help people when they are in that stage of their life and when they're in terrible suffering. And then I did my first mission with MSF in the field, which was in 1982, so some years later. We had very little guidelines by that time. You know, professionalization of humanitarian healthcare was not yet really a topic. But I was a doctor, you know, we had to treat patients, we had some drugs, and we had some simple guidance on what to do. Again, of course, what to do when patients were at the end of their life and we couldn't do anything for them anymore, had no idea what to do. And I remember that probably I saw the first AIDS patients in my life. Of course, nobody knew it was AIDS then. And people were dying in front of our eyes. We didn't know what to do. We couldn't help them. And we didn't do anything, really. And I felt, again, this disempowerment I had felt here at the hospital in Geneva. And many years later in MSF, there was a very, I would say, very creative and pharmacologist who was also very close to what do people need and how can I help. So of course it was about drugs and quality of drugs, etc. But Jacques Pinel also very much looked at, you know, what can we do to improve the lives of our patients. And he was one of the first ones, I think, to say, we have to do something so that we can deal with pain, that we can deal with end-of-life suffering. Morphine was impossible to get into those countries. And he was really somebody trying to think about that and pushing that agenda. And now, of course, in 2018, we're much further ahead. In Switzerland, we have palliative care. I'm sure you have it in the countries where you come from. It's something which is much more established, which medical students learn about. All that didn't exist then. And I think in humanitarian organizations, it slowly also is making its way. It's not yet something probably which is the highest priority, because we always try to save lives, so that's what it's about. But how do we do when you accompany people who are getting to the end of their lives or who are in terrible suffering? And I'm very pleased that we now have some more research, some more information on what the needs of these patients are and what makes the difference. And I think a lot of it is about what makes the difference. And when we talk about small things, small acts, is that simple small things can make a difference. Of course, we also need the technical means to help, but we may also need other things. So for me, it is really a long journey in the humanitarian world, which is also a long journey in our own healthcare systems. So I think it really speaks to that experience I had over the past 40 years, really, with this subject really been evolving. And I'm very hopeful that the information which comes out of this research also will push humanitarian organizations to take this more into consideration in what they do. So this was just to set a little bit the scene for the evening. And I'll now hand over to Lisa, who will introduce a little bit the people who will be on stage tonight. And please.
Very much. Thank you. Thank you very much, Doris. And I want to say thanks very much also to Sarah and to the University of Geneva for hosting us. It's been a tremendous opportunity for us to be able to bring our research here and to meet with some of the knowledge users and share some of the ideas with people who are directly involved. Thanks also very much to Alexandrina, who's been chasing around the back of the room, and Florence from Sarah, both from Sarah, who've been a tremendous help for the work that we've done. The Humanitarian Health Ethics Research Group is really the development of a program for the last decade or so, where we've been examining the lived experience of humanitarian healthcare practitioners, living in the field, working in the field, and finding that they're faced with challenges that they're either not prepared to manage or not supported to manage, and then have to live with the moral residue and the moral distress of those experiences. More recently, we've been involving the local researchers and local healthcare practitioners and the patients to hear their stories of what it's like to be on the receiving end of a humanitarian healthcare practice. And after the 2014 Ebola outbreak, 2014 to 2016, one of the questions that emerged for us in all of the research that we were doing was, what was the role of palliative care? What happens when you reach the point where there's supposedly nothing left to offer, and people are, no matter what their intentions, and no matter how well we go prepared into the field, people are still necessarily going to die. And they'll either die because they were dying before the incident and the disaster happened, or they're dying because in the long run there's no way to cure and rescue everybody involved. So we were fortunate enough at the time to be able to make an application for 2 studies. We made one on research ethics during Ebola, and a second one for palliative care and complex humanitarian aid. And we're grateful to the R2HC, the ELRA program at R2HC Research to Humanitarian Health Action in humanitarian health contexts, thanks. And Simon Picard, who is here in the room, I believe. So we're very grateful for the funding that we received for that. After 2 years of doing interviews, a cross-cutting theme across all of both the studies has been the nature of small gestures and what small things can do, while at the same time recognizing that just small things may not be enough in the long run. Part of our inspiration for that thematic came from Paul Bouvier, from Dr. Paul Bouvier, whose paper a few years ago on the nature, again, of small things in humanitarian acts really inspired the way we started to think and the way we applied that lens. So this evening we're going to have an opportunity to hear from Dr. Bouvier about some of this thinking, and then afterwards to hear from a panel that consists of our collaborators and researchers, some people from Canada and some people from the settings. So I will do those introductions after this. But first I'd like to introduce Dr. Paul Bouvier. Dr. Bouvier works with the International Committee of the Red Cross right here in Geneva, and is the course coordinator for the HELP course, which is the training course for most of the for practitioners going into the field, and initiated some number of years ago the inclusion of ethics and management of ethics in that training course. I think probably this was a pioneering gesture. I don't know that others have done quite so much in their training. And in that thoughtful process, I think over the years has integrated case study management and discussion of these issues so that practitioners going into the field can be prepared to think about the issues and think about creating the space for discussing ethics before they move on. And that's been quite an inspiration for us, and I think probably an inspiration for many of the students who they've encountered. As a former ICRC senior medical officer, he's a medical doctor with a specialization in pediatrics and public health, an associate lecturer at the Institute of Global Health at the University of Geneva, where he's carried out research and prevention programs on child sexual abuse and violence. Along with his medical training activities, Dr. Bouvier has also applied the perspectives, I guess, he developed through his various roles and field experiences in crises into various philosophical reflections and medical humanities activities. Those of you who are familiar with Paul Ricoeur will recognize, I think, some of that influence in the talk even this evening. Along with his medical training activities, Dr. Bouvier has also, back again, sorry about that. So from published reflections on small things and humanity on the part of delegates visiting people in detention, to an art history lesson on Francisco Goya's disasters and war prints in prefiguring Dunant's Solferino relief efforts by several decades. Dr. Bouvier has demonstrated his skills as a rich and diverse thinker on issues of suffering, morality, and what it means to be human. And a further complement to his professional work and his intellectual writing, he has consulted on exhibitions at the International Red Cross and Red Crescent Museum, which I think we'll be treated to seeing a little bit of this evening, here in Geneva, including the main humanitarian adventure halls and the most recent publication, Prisoners' Objects. So I'd like to welcome and thank Dr. Bouvier for coming this evening.
Thank you very much, Lisa. Now that should be a small talk about small things in complicated situations. It's about small acts in the midst of crises, disasters, armed conflicts. And as Lisa Schwartz said, it's based on an article I wrote a few years ago. And it will be based also on this book that you can see here, which has been published last year by the Museum of the Red Cross, which is about prisoners' objects. And I will use some illustration to illustrate my talk tonight based on that book. These are objects given by prisoners during visits made by delegates of the International Committee of the Red Cross, the ICRC. We visit close to 1 million detainees every year now, which is a huge activity. And my reflection tonight is about what is the value of this activity. This reflection started with a question asked by a psychologist, expert on resilience. He remembered a document from the ICRC, an article or a report, he was not sure, where former detainees were asked what was the most important event in their detention and what helped them most during their detention. And many of them would say, it was drinking a cup of coffee with a delegate of the ICRC. So the question was, what was in the cup of coffee that could last so long and help so many people during detention, sometimes in very awful conditions? It reminded me also about this engraving by Francisco de Goya, who asked the same question, what is the use of a cup? And the question of Goya is actually, we are here in a famine in Madrid, and we see this lady providing a cup of soup to help somebody who is going to die. And of course the question here is that, is it enough? And what is the value of that? So you have the both elements. At the same time, another colleague from ICRC, back from the field, in very difficult situations of conflict, came to me with a help course and was asking, I work in an extremely difficult situation in a country where we have people tortured chronically, again and again. We do the visits, we have confidential interviews with the authorities, and we see no change. And do we have to continue the visits? We are the only ones to visit these places. People are totally abandoned, isolated if we leave that. And then the same question came behind this terrible question about our powerlessness, incapability to prevent torture in that case. Is that also, what is the value of visiting these people? Clearly, the purpose of the visits that we do when we enter into a place of detention, the purpose is to prevent abuse, to prevent torture, to promote respect of people, to improve the conditions of detention and of treatment. But we also see when we go to the field, when we work there, that the visit itself has some value. It is a unique moment in the life of many detainees in which they meet with someone external to the detention system. Many of us remember private talks with detainees around a cup of tea, of coffee, cookies, which become real encounters, sharing about our lives, families, beliefs and hopes, and sometimes just about everyday small things, everyday life, or even sometimes some humorous situations. So these are intense moments of shared humanity. I will share with you a few elements and a few events in which I've been involved, actually. One of them is about pictures, postcards, actually, small postcards distributed by the ICRC delegate in a high-security prison where people were isolated, ill-treated in the ways that they were like abandoned and isolated, and in a very difficult situation. And one of the activities when I went there to visit them as a medical doctor, I was surprised to see big amounts of postcards that the delegates would have with them when they entered into the camps to distribute to the prisoners. Some prisoners would take about 20 to 30 of them. What did they do with the postcards? First, they would put it on the walls, as if to remind them that there is some beauty in life, in the world. You see the kind of postcards. These are original postcards from there, from this place. Flowers, sunshine, animals, etc. A second use they did with that was to send postcards to the families. They have the possibility to send Red Cross messages. They receive messages from the family, and the ICRC plays that role as well. But sometimes they just send a postcard without any word, a picture with sunshine, animals, as if to say, I'm not able to explain you what happens. And it could even be perceived as insulting. They want us to have perfume because you stink, or what is it? So there is a profound mistake here from the colleague who made a confusion between the bottle of perfume and the process, which is a relational process. It was an encounter between one delegate and a detainee, which concluded to giving the perfume. But it's not something that you can generalize. And it makes us think about who is doing humanitarian action. Is humanitarian action possible to be done by robots, by non-human actors? To some extent, yes, of course. Some technical acts will be done much better, perhaps at least much safer, by robots. I think it's the case already. But this unique relationship between human beings, this sense of humanity that we restore when we have adequate behaviors and adequate understanding and relationship with people, it's something we can never replace. And as was said before, in many contexts, it's the only, perhaps the last thing that we can do when we are in very extreme situations. It can be in detention, it can be situations of war, disaster. So each human experience is unique and irreplaceable. There is no ready-to-wear solution to humanitarian care. A request for a few drops of perfume emerged spontaneously in a particular place. And through these drops, a detainee felt recognized as a human being. This is a relational and deep ethical experience, which results from mutual recognition as humans. The same liquid might be meaningless and even offensive, insulting in another context. people working in humanitarian action find their own way of humanitarian care. They work with their own humanity, which is a combination of respect and sympathy. So the examples given suggest that, lamentably, our current models of management and evaluation also fail to consider that essential dimension. What indicator do you use to evaluate the quality of relationship? What indicator in your budget, how would you describe that? It is very difficult, and the danger is that we forget about that essential aspect of the work that we do. Small acts of humanity sometimes have irreplaceable value. Their effect can go deep into the person, in their soul, help them to survive, to recover a sense of humanity. It can spread to other people around, impacting on their own lived experience. And as in the song of Georges Brassens here, such things remain within the person for years. Thank you for your attention.